So let's move on with a specific example. I think that in your practice, we have the biosimilar bevacizumabs now. And how did you end up adopting the biosimilar bevacizumab in your particular practice for metastatic lung cancer, for example?
So Adam, that's again, I think I really want to share my expertise as well as my opinion on the role of the biosimilar that it can play in addressing Part B drug price. We are an oncology care model practice, and one of the foundation of OCM is to maintain the quality of care or improve it, improve patient experience and reduce the cost of care. I cannot not offer patient what they deserve even if it's expensive, but when I have a choice, for example, in stage 4 lung cancer, we have a large population of stage 4 non-small cell lung cancer that we treat at our clinic, being in South Carolina, Tobacco Belt.
Right.
So bevacizumab has played a significant role because we are able to reduce the cost, ASP, and what we project that by 2021 December, my total drug spending will go down by about 15 to 17%. And it's based on the fact that history of biosimilars has shown in the last 2 years that within 2 years, the ASP drops to about 30 to 35%. 50% of my total drug budget is in biologics. So when I extrapolate 35% saving in the biologics, my total drug budget would go down by 15%, which is almost $1 million plus savings to us. And we feel that we can be part of playing the role of a steward or trustee of the society by helping spend less without compromising the care. At the same time, what we don't realize is a lot of patients who are living on paycheck to paycheck with Medicare only. Even 30% reduction in their out-of-pocket costs could save them $100 a month. It may not sound a whole lot to me and you sitting here, but when you look at a typical traditional average Joe who lives either in South Carolina, Mississippi, Georgia, in that part of the country, who has to drive 30 miles one way, a saving of $100 would be about 8% of their paycheck from Medicare. And that's a huge saving for them as an out-of-pocket cost.
No, I totally agree with you. I mean, I think that the issue is, this is a big deal not only for the patients, but actually for the practices as well. One thing that and I'll get into this when we talk about trastuzumab in our practice, the question I have is, you probably have some 340B. Do you have 340B hospitals or not in your practice?
We are not. We are in.
So you're not. Okay, so we'll talk about that because that's a big question because the whole 340B system is totally different.
It is
different. And it's like kind of what you get, and you get the lowest ASP that you can, and it's a really interesting dilemma. We'll get more into that when I talk about that, but that's a little bit different scenario. But you still have to deal with multiple insurers.
It does.
And multiple payers, some of which may already have preferred a particular biosimilar. How do you handle that?
So
or how did you handle that with the bevacizumab? I mean, also, aren't there 2 or 3 that are available now, or just one?
I think right now there's only one.
Just one.
I think the 2 more approved, I think they'll be coming later on.
Right, but right now you have one. I think it's Mvandi. What's it called?
Mvasi.
Mvasi, yeah, because I don't use bevacizumab. We're not allowed to in breast anymore, so I can't use it. But anyway, so there's Mvasi. So you decided to do it. So there really is not a decision between any 1 or 2. It's between that and the originator, bevacizumab.
Right, exactly. And you're right on the spot because, we went through that issue in the other part of biosimilars. We had 3 biosimilars in the filgrastim space.
Right.
And we had coverage issues. So I wrote a very long letter to our state Medicaid and said, listen, we have been asked to reduce the cost of care. Biosimilars offer us a fundamental paradigm shift in addressing that using new class of drug without compromising care, but if state government does not work with us, how can you expect us to provide this sort of care? Right. And they were kind enough, they listened to us, and they started approving biosimilars in the Medicaid as well, which was a very pleasant surprise. It all comes back to education. We had the same challenge with our commercial insurance. So I made 3 trips personally to state commercial insurance's chief medical officer. I made a presentation and showed them that what's at stake is not few dollars of saving, it's billions of dollars.
So
that
they
could be
were
saved.
even though, they said, even though you promised them at least a 30% reduction in the ASP, they were still like, no, we don't want to do this? Really? You had to be convinced? I'm shocked.
I'm telling you, I don't want to bring this word.
Not to diss any politicians listening to this, but I am kind of shocked. I don't want to say money. Yeah.
Well, there are so many middlemen between,
Good point.
and so the middleman will advise commercial
Got it.
insurers that, this is going to be best because we make more discount at the back end.
Right, got it.
It comes
Okay.
down to rebates as well.
I understand that. And so did people need education about these drugs? Did they think they were different? Or, how did you say, listen, other than this is cheaper, how did you kind of make the point to them that, yes, this is kind of the same? You said that we think this is the same, but it's cheaper. I mean, how did you make that argument to them?
So I myself took a lot of training in biosimilar space, and then I started solo battle, at my clinic, and then started talking at the co-op. So at two organizations, I steered the formation of biosimilars committee. Okay. It was almost like I was self-propelling myself to do that. And at the end of the day, when you start doing something very vigorously, they say, well, you become the chairman. I didn't know what I was asking for, but now I'm dealing with that.
And do you have any points? I mean, you were able to do this. You're self-motivated. You learned on your own. Do you have any points for somebody who wants to kind of get involved in this then at their level or their part of the country? I mean, how would you do it?
Absolutely. I think in my experience, it's the education of the payers when you look at the payer battle. Education of physicians about the process of approval of biosimilars, education of physicians that Europe has been using it since 2006. They have used over 700 million unique doses and still have not seen any adverse outcome that
that's
people
very
otherwise
big.
think. Exactly.
People don't understand that. That's a very big point to make.
Yeah. So they are safe, they're effective, they're less expensive, and they've reduced the cost of care by anywhere between 36 to 50% in Europe, almost 35% in the US so far for those who are in the market so far. So I think education will definitely help us bridge that gap that we're facing right now.